And welcome. Today we're diving into one of the most fundamental and, let me tell you, high-yield topics in obstetrics, antenatal care. Whether you're prepping for your university exams or gearing up for NEET PG, getting a solid grip on this is absolutely non-negotiable. So let's jump right in.
Right, so first things first, let's build our foundation. The Blueprint for Good Antenatal Care, or ANC, really has two main parts. One is the clinical plan that we follow, but just as important is the second part, what we teach the patient. And we'll start there with the absolute red flags she needs to know. Okay, let's talk about these danger signs. These are the critical alerts that every single patient must be taught. It's our job to make sure they understand that things like a high fever, vomiting that just won't stop, or any kind of vaginal bleeding, that's what PV or pervaginal means, are not to be taken lightly. Any one of these means you tell them, come to the hospital immediately. No negotiation on these points.
Now, let's get to the clinical side of our blueprint. How do we actually put antenatal care into practice? Well, this section is all about the what and when, the schedules, the essential tests we need to run, and the vaccinations that protect both mother and baby.
So how often should a pregnant lady see her doctor? In an ideal world, it's about 14 to 15 visits. The WHO says, okay, a minimum of 8 is good. But for our exams and for practice in India, you must remember the Government of India guideline. That's a minimum of 4 visits. It's easy to remember. Think 1 visit in the first trimester, another in the second, and 2 visits in the third trimester.
At the very first antenatal visit, there's a whole bunch of tests to do, right? Here's a great way to remember the key ones. The mnemonic CAHUSTA. It's super handy. It helps us remember to check blood group and Rh type, order a complete blood count and urine routine, screen for HIV and hepatitis B, run a VDRL for syphilis, and screen for diabetes. This gives us a really solid baseline for the rest of the pregnancy.
Okay, now let's take a specific situation, the Rh-negative mother. This is a classic question. The protocol is actually very logical. Step 1, you check the husband's Rh status. Now, if he is positive, there's a chance the baby is also positive, right? So we do an indirect Coombs test, or ICT, on the mother at her first visit to see if she has any antibodies. Then we repeat it at 28 weeks. This is the standard of care to prevent isoimmunization. Simple.
Vaccinations, another super important topic. Every pregnant woman gets 2 doses of the TD vaccine, that's tetanus and diphtheria, 4 weeks apart. But ACOG, the American College of Obstetricians and Gynecologists, also recommends the Tdap vaccine. The key here is that P. It stands for pertussis, or whooping cough. Giving a single shot between 27 and 36 weeks gives the newborn some crucial passive immunity. It's a very important point to distinguish from the standard TD vaccine.
All right, next up, let's talk about nutrition. A proper diet and the right supplements are literally the building blocks for a healthy baby and a strong mother. We're going to break down all the essentials, from calories to specific micronutrients.
Okay, students, pay close attention to this slide. The difference between the prophylactic and therapeutic doses of folic acid is a very, very common exam question. For all pregnant women, we give a prophylactic or preventative dose of 400 micrograms daily. But, and this is the important part, for a woman who's had a previous baby with a neural tube defect, the dose is 10 times higher, 4 milligrams daily. This is a crucial point. Please don't get these two confused.
Now, what about calories? Does a pregnant woman really need to eat for 2? Well, not exactly. The extra energy she needs actually increases as the pregnancy goes on. It's only about 85 extra kilocalories in the first trimester, then it goes up to about 470 in the third. So on average, throughout the whole pregnancy, it's about 350 extra kilocalories per day. Now for our other micronutrient superstars. Iron is absolutely vital to prevent anemia, so we start 60 milligrams of elemental iron from the 4th month. This usually comes in an IFA, or iron folic acid tablet. Calcium, for the baby's bones and teeth, is also started from the 4th month, at 1,000 milligrams daily. And please don't forget protein for growth. The mother needs an extra 10 grams in the 2nd trimester, and that jumps to an extra 20 grams in the 3rd. Pregnancy isn't always smooth sailing. There are several common issues that patients will come to us with, so in this next section, we'll talk about how to identify and manage some of the most frequent complaints, from nausea and vomiting to feeling dizzy. This slide shows the mechanism behind supine hypotension syndrome so clearly. Look, when a pregnant patient lies flat on her back, the weight of this big uterus can press down on the inferior vena cava. What does that do? It reduces the blood returning to the heart, which drops the cardiac output and causes her to feel dizzy. The management is incredibly simple and effective. Just advise the patient to lie in the left lateral position. That takes the pressure right off.
It's really important to know the difference between simple morning sickness and its much more severe form, hyperemesis gravidarum. The key difference is right here in the definition. It's not just some vomiting. It's persistent vomiting that leads to significant weight loss, more than 5% of her pre-pregnancy weight, and, critically, ketonuria, which means there are ketones in the urine. That's a sign of starvation.
Management of hyperemesis is a very important topic, and this flowchart makes it simple. The first and most critical step is to check for hypovolemia, or dehydration. If there is no dehydration, we can try to manage the patient with oral anti-nausea medicines. But if hypovolemia is present, that patient must be admitted. No questions. They need immediate IV fluids, along with thiamine to prevent a serious complication called Wernicke's encephalopathy, and of course, IV antiemetics. This step-by-step approach is key.
You see, not all pregnancies are the same. Some carry a much higher risk of complications. So in our final section, we'll learn how to identify these high-risk pregnancies and understand the system we use to flag them for special care and attention. So, what exactly makes a pregnancy high risk? Well, there are several key factors we look for. For example, extremes of maternal age, being either very young, under 20, or older, over 35. Severe anemia, with a hemoglobin less than 7, is another major red flag. Having twins or triplets, or a history of complications like preeclampsia or a previous C-section, all of these things automatically put the pregnancy into a higher risk category. That means they need much closer monitoring.
To make identifying these risks easy in a busy clinic, we often use a color-coding system on the antenatal card. It's very intuitive. Green means no risk factors, everything's going smoothly. Red immediately signals a high-risk pregnancy. Blue is specifically for pregnancy-induced hypertension, and yellow is for other conditions like gestational diabetes or hypothyroidism. It's a simple but really effective way to triage patients.
Okay, time for a quick-fire revision of the absolute must-know facts from this session. Ready? 4 minimum antenatal visits, the 10-fold difference in folic acid dosage. Hyperemesis is defined by more than 5% weight loss plus ketonuria. And for supine hypotension, the magic bullet is the left lateral position. Please lock these points into your memory. They will save you in exams.
And we'll end with a thought for you to take away. Everything we've discussed today, the schedules, the tests, the management plans, it all really comes down to one question. How does doing all of this early and correctly directly impact the health of the mother and the baby? That is the core of why antenatal care is so incredibly important.